Okay.
Thank you so much for the invitation to be here today. And no, it doesn't work on. And for the very nice introduction. The title of my talk is Surgical Simulation Training Implementation, and I've called it Research, Resources and Reality. I'm responsible for the virtual reality training in Copenhagen, Denmark, in ophthalmology, and I'm a member of the National Educational Board. And I have a PhD in assessment and training of complex technical skills. And this is my research group consisting of Morten Lacour, who is a professor in ophthalmology, Lars Konge, who is a professor and head of research at Copenhagen Academy for Medical Education and Simulation, and Mads Jacobsen, who is a new PhD student in our group. And I have no disclosures. It is essential that simulation-based training is integrated into structured curricula for surgical education. And this process can be facilitated by using a model for curriculum development. For example, this 6-step approach developed by Chairmen. And before you get too exhausted by the thought of it, I'll just quickly say that I'll primarily go into these 3 steps. I'll just briefly mention some of the other steps because they are all related. The first step, problem identification and general needs assessment, is highly contextual, related to context, so there may be big national and regional differences. Some of the problems that might be identified is the less working hours for doctors, ethical consideration including patient safety, and more demanding procedures requiring a more complex skill set of the surgeons. And we've completed a national needs assessment in Denmark, inviting stakeholders to provide their opinion on which procedures should be integrated in a simulation-based curriculum. And our results may not be relevant for UK and US due to national differences in the way we organize a cataract surgical system, but it may be relevant for other European countries and especially Scandinavian countries. I'll not go into details, just briefly mention that the procedures were ranked according to the frequency of the procedures, how many operators should be able to perform the procedure, the impact including the patient discomfort when performed by an inexperienced surgeon, and feasibility, which includes the available simulation models. The next step is goals and objectives, and an essential part of this step is assessment tools, both for the simulated and clinical setting. And they need to be developed and investigated, and both are needed to ensure that surgeons reach the desired level of competence in both in a patient-safe environment. And we would like to confirm that the competence, of course, translates to the clinical setting. And various approaches exist for the training and assessment of cataract surgical skills and the measurements of performance improvement. These 3 of these is the results from our validity investigations of the automated metrics provided by the Eyesi simulator, and the OSACs done by George we've used for some of our research. So we have investigated almost all of the modules on the cataract interface of the Eyesi simulator, and we've looked at various sources of validity evidence. And this has resulted in a mastery learning program, which we call the Copenhagen criteria for cataract simulation training. And that includes 5 abstract modules and 2 procedural modules, the capture rexes and the faculty divide and conquer. And from this, we've done this calculated pass-fail standard or criteria, which is 600 points in two consecutive sessions, or 2 times in a row. And this is an example of an individual's progression through the program. We have done something similar for the vitreoretinal interface, which I will not come further into this time. After the definition of goals and objectives with your training, you should decide on educational strategies to use. And we've been looking at those who have evidence in order to maximize the learning effect. And these are all, they have shown to have moderate effect sizes. So we do the spacing of sessions, task variability, and feedback. So we use these, and of course the mastery learning, which is also called competency-based learning or proficiency-based training. And this is an example of the feedback provided by the simulator, as you all probably know. So the next part is the implementation part. And that's what I've called research, resources, and reality. Obtaining political support and securing resources is a lot easier when you can show relevant research findings. So this is just shortly, this is a study where we have investigated the clinical effect in a prospective study of simulation training. And what we found was that there was a significant effect on in real life when we looked at the OSAC's performance score in the OR after having completed our mastery training program. So our trainees, they improved by 32 and 38% when we looked at their performance score in real life after having completed our course on the Eyesi simulator. And because of this strong evidence, it was not difficult to obtain political support, and it's now a requirement in the capital region of Denmark that all doctors must train on a simulator before doing procedures on patients, including cataract surgery. And this is an article from a Danish newspaper in 2015. For us as an ophthalmology department, it has had significant benefits to be associated with a simulation center. CAMES, Copenhagen Academy for Medical Education and Simulation, is part of the University of Copenhagen, and it also have regional anchors. And they have a significant knowledge on simulation-based training in various surgical specialties. They also have medical students employed who helps us in the training of the residents. And without this infrastructure, it would not be possible for us to offer this structured curriculum that we do. So it's very important to secure relevant resources. However, Colin McCannell also mentioned it. We know that equipment is not really used if it's not mandatory. I have a colleague at CAMES who have completed a study in laparoscopy where they had these take-home trainers for the training of laparoscopy skills. And all the trainees said they were going to train all the time if the equipment was available. However, the results show that they were only training when they just received the equipment and just before a test. It was not touched in between. So, yeah. The last part is the evaluation and feedback. And when developing and implementing these educational interventions, like simulation-based training programs, it is very important that they undergo evaluation on a regular basis. So it's both to ensure that the previously identified objectives are met and that the training program remains up to date. One model for evaluating training programs is the Kirkpatrick model, as you probably already know. It's not enough to show that people are satisfied with the course. We have to show that they actually learn something and that it is cost efficient. Previous evidence have shown that simulation-based assessment often correlate positively with patient-related outcomes. And although these surrogates are imperfect, tools with established validity evidence may replace workplace-based assessment, which are often very cumbersome to collect. So you can use the simulation-based assessment instead for evaluating select procedural skills. And I believe that we are there when it comes to the automated metrics provided by the Eyesi simulator when we use select modules for the evaluation. Thank you.